All right, this is your endocrine review video. So we're going to go through all these endocrine pathways, including we'll talk about the pancreas and all the hormones it makes as well. Okay, so first pathway, the hypothalamic pituitary thyroid pathway. So this starts in the hypothalamus, which you know is part of the brain, right? This connects the nervous system to the endocrine system, right? So this hypothalamus produces all these releasing hormones that act on the anterior pituitary gland. The posterior pituitary doesn't make any hormones, right? But it stores two hormones, antidiuretic hormone and oxytocin, which I don't think I put any slides on here about that. We talked about all that in class already, so I'm just going to get into it. So thyroid releasing hormone is going to trickle through those little blood vessels and stimulate special cells in the anterior pituitary to release thyroid stimulating hormone. Then we see here thyroid stimulating hormone is going to stimulate special cells in the thyroid gland. Really special? I don't know. Follicular cells, and follicular cells make thyroid hormone. So there's two thyroid hormones here made by the thyroid gland, T4 and T3. The large majority is T4. T4 is the inactive thyroid hormone. It's called tetraiodothyronine. It's a protein hormone, and iodo meaning iodine. You need iodine to make these thyroid hormones. Well, usually we don't call it tetraiodothyronine. A lot of time we refer to this as thyroxine, and you might be familiar with that as a medication, levothyroxine, or the brand name Synthroid. Think of it as like synthetic thyroid hormone. It's basically synthetic T4 you give patients who need thyroid replacement. Anyway, T3, this is triiodothyronine, so one less iodine. This actually breaks down into T2s. It's metabolized. There's enzymes called deiodinases. You don't need to know that. But T3 is the active hormone. So where does all this T4 go? T4 has to go to the liver to become activated, and T4 is converted to T3 via those enzymes, and it spits out all this T3. So you do have to have a functioning liver to convert T4 to T3. So what does T3 do? Well, metabolism. What is metabolism? So basically two things. It's the efficiency of breaking down fatty acids and glucose into ATP. So what everyone thinks metabolism is the person that can eat a whole bag of chips and a whole pizza and they don't gain any weight. Why? Because they quote unquote burn the calories off. What is that burning? It's taking the fatty acids and glucose and converting them into ATP within our cells at a faster rate. So we know excess fatty acids and glucose will get stored as body fat. But if we turn it into ATP faster, we need more, then less will tend to get stored as body fat. Okay, then increased rate of protein synthesis, we break protein down. Okay, faster. Well, okay, what's the point of that? Well, we see people with hyperthyroidism, they end up getting muscle breakdown and muscle weakness because their increased rate of protein synthesis. All these cells need lots of amino acids, so you start breaking down protein faster than you can eat it, basically, and you can break down skeletal muscle tissue. So we know rising levels of T3 and T4 will have a negative feedback loop on TSH and TRH, which is not depicted here. So hyperthyroidism and hypothyroidism. So in hyperthyroidism, we see elevated levels of T4 and or T3, and because of negative feedback, we'll have decreased TSH. But we talked about this in class as well. What happens if you have a tumor in your pituitary gland spitting out TSH, overstimulating the thyroid, leading to hyperthyroidism? Sometimes we call that central hyperthyroidism. In that case, you'd have high TSH and high T4 and T3, but for testing purposes, don't worry about that. Your nursing instructors will teach that to you later. Now, hypothyroidism, so this is decreased levels of T4 and or T3. So usually this is an autoimmune cause, or we'll get back to that, sorry, or aging. And then because we have low T4 and T3, we'll have less negative feedback. That's how I put it, less negative feedback. So we crank up the dial on TRH and TSH, and we've elevated TSH. But again, if you had a condition where you're not making enough TSH, well, you would have low TSH and low T4 and T3. That's central hypothyroidism. So symptoms of hyperthyroidism, well, anxiety, weight loss, so you don't change your activity or your caloric intake, but you're losing weight, resting tachycardia, maybe even palpitations, diarrhea, muscle weakness, muscle loss. So these people aren't just going to lose body fat, they're also losing muscle mass. So most common cause in the United States is Graves' disease. There's also toxic, nodular goiters and things like that. And then there's fictitious hyperthyroidism. So what if you have a patient that's stealing their grandma's Synthroid and taking it to lose weight? Well, they could be giving themselves symptoms of hyperthyroidism when they don't have it. Hypothyroidism, so Hashimoto's is probably the leading cause in the U.S., so lots of autoimmune causes. And we could say maybe with aging, the thyroid's not working as well. And with hypothyroidism, people have the opposite: fatigue, weight gain, constipation, maybe depression because they don't feel good, they're tired. So this is depicting the same thing again. The only thing this is showing, so we see the negative feedback loop. Oh shoot, we saw the negative feedback loop. And also I was talking about binding proteins. So a lot of these hormones are bound to proteins, like thyroid hormones bound to thyroid binding globulin, cortisol's bind to cortisol binding globulin. There's another hormone called sex hormone binding globulin that binds to sex hormones. So when you get hormone levels, sometimes you can check free and bound levels, or total levels we say. So if you get TSH as a screening panel and it's high or low, well, you know there's some kind of thyroid problem. And then you get a thyroid panel and you check total T3, free T3, and there's a lot of other like reverse T3s, all these labs in there. They can help elucidate what the exact cause is of what's going on. So next pathway, so hypothalamic pituitary adrenal pathway. So this starts in the hypothalamus. The C's cut off, that's great. And that is the corticotropic, screw this up, jeez. Corticotropic releasing hormone. That is going to stimulate the anterior pituitary to release this hormone called adrenocorticotropic hormone, ACTH. Okay, long word, but if you break it down, adreno refers to the adrenal gland, cortico refers to specifically the adrenal cortex, and a tropic hormone is a hormone that causes the release of another hormone, and this is going to cause the release of cortisol, or we can say cortisone. Okay, the abbreviation is ACTH, and that's usually what you're going to say. So ACTH is going to stimulate the adrenal cortex. Let's talk about the adrenal cortex for a second. So the adrenal cortex, that's the outer shell of the adrenal gland, and we have the adrenal medulla. So the adrenal medulla, that releases epinephrine. Okay, that's from sympathetic stimulation and not ACTH necessarily. The three layers of the adrenal cortex: zona glomerulosa, zona fasciculata, zona reticularis, as Dr. Smolinski says, salt, sugar, and sex. So aldosterone is a hormone that maintains blood volume. This is stimulated by something called the renin-angiotensin-aldosterone system. And the renin-angiotensin-aldosterone system is something you'll learn in the renal system and when you talk about blood pressure. This maintains blood volume by increasing sodium and water reabsorption in the kidney, and also promotes potassium secretion. Very important hormone, and you'll talk about that later. But basically, if we have low aldosterone, blood volume will be decreased, and this can affect our blood pressure by lowering it. So we're going to focus on is the zona fasciculata. This makes cortisone, and cortisone gets converted to cortisol in the liver. Okay, and the zona reticularis makes sex hormones. Usually they're androgenic or really parent hormones. The main primary one is dihydroepiandrosterone, or DHEA. Okay, so cortisone gets converted to cortisol in the liver. What does cortisol do? Well, it increases blood glucose. That's what we're really going to focus on. And how does it do it? Well, it's a catabolic hormone that's going to affect the liver by causing glycogenolysis, so breaking down glycogen, and gluconeogenesis, so forming glucose from non-carbohydrate products. There's a couple of them, but mostly amino acids. And that's important to understand when patients have excess cortisol. They can, like in Cushing's disease, they get muscle wasting. Why would they get muscle wasting? Because of gluconeogenesis. Damn gluconeogenesis. Gotta know that word forever. What a pain in the ass. Okay, so cortisol gets released in the times of stress. Well, what are stressors? Well, there's physical stressors, which can usually be a good thing to a certain extent. That can be exercise and physical labor. We need to increase blood glucose for skeletal muscles that are going to be needing them for potential extra energy. And then fasted states. So when you wake up in the morning, we go over here. So cortisol is highest in the AM. It's something called the dawn phenomenon. Okay, we wake up, we get a burst of cortisol to maintain our blood glucose. So if you're someone who skips breakfast, especially if you go to work and you have an active job, you're gonna have higher levels of cortisol. Is that bad for you? No, because you're not taking in food, so you need more cortisol. When you have diseases like Addison's disease, well, you don't make enough cortisol because adrenal cortical insufficiency, you don't eat or you go into times of stress, you don't get the cortisol release, and your blood glucose can drop and you get hypoglycemia. Okay, now psychological stress, that's the bad stress. So again, you're sitting at a desk all day, you're eating donuts and a bunch of food, and you have really high levels of sympathetic output and cortisol. Well, it's going to free up all this glucose. Where's this glucose going to go? Well, body fat. There's actually studies showing there's more cortisol receptors for fat cells, kind of, or something like that. I don't know. To increase abdominal fat. Okay, we know in Cushing's disease we get fat redistribution, and the biggest things we see is central obesity, as well as that buffalo hump and moon face. So it's also immunosuppressive, really anti-inflammatory, and we've used that to make this class of drugs called corticosteroids. Corticosteroids have cortisol type effects in the body. So they're anti-inflammatory, whether you use them locally as a cream on your skin, like triamcinolone or hydrocortisone cream, or use them locally with injections, so injecting into a joint for knee arthritis or a shoulder for, shoulder bursitis or something like that. So again, methylprednisolone, triamcinolone, dexamethasone, which are different ones, or you take them orally and have a systemic effect like prednisone. You could also do IM injections and have a systemic effect as well to treat a variety of conditions. Okay, so the anti-inflammatory thing is good. But again, the problem is you're sitting at a desk all day, well, you're increasing blood glucose. The excess blood glucose gets stored as body fat, causes insulin resistance. It's an immunosuppressive effect. Well, if you have high levels of stress, you're more likely to get sick. Well, technically, yes, you are. So that's important to understand. Okay, so increasing blood glucose can have a lot of detrimental effects long term, especially if you're diabetic. Steroids will jack up your blood sugars bad. Even people who are well controlled, so you gotta be careful. What was I going to say? Anti-inflammatory, blood glucose. Oh, and corticosteroids also have aldosteronogenic, that's not a word, aldosterone type effects in varying amounts. So that's why people on corticosteroids say, oh, I'm gaining weight and I hold on water weight, my blood pressure goes up, etc. Okay, and then negative feedback as cortisol levels increase. They're negative feedback on ACTH and corticotropic releasing hormone. Cushing's disease, I cut off the C. God damn it. So Cushing's disease, high levels of cortisol. So is ACTH going to be high or low? With high cortisol, it should be low ACTH, like the thyroid disease we talked about. Well, it depends. If you have a tumor in the adrenal gland pumping out cortisol, well, then we will have more negative feedback and we'll have a lower ACTH. If the tumor is coming from your pituitary gland, we talked about this with thyroid as well, it's going to pump out high levels of ACTH. You have high ACTH and high cortisol. Addison disease, adrenal cortical insufficiency, usually it's due to autoimmune cause, kind of damaging the adrenal cortex. We'll have low cortisol, so that can lead to hypoglycemia. Low aldosterone can lead to hypotension, and potentially even low sex hormones, not written here, which has more of an effect in females sometimes. So we decrease some of those parent hormones, like I said, DHEA. And here we're going to have high ACTH because we're going to have less negative feedback. So symptoms in Cushing's disease, this is important to understand. Cortisol, we already talked about all of them. Excess cortisol, excess glucose, this can lead to insulin resistance and overt type 2 diabetes. Fat redistribution, so especially central obesity. I know that for testing purposes maybe. Buffalo hump, mood face, and then muscle wasting. Why muscle wasting? Because of this gluconeogenesis. That's all. Okay, the next pathway, so the sex hormone pathway. So this starts with gonadotropin releasing hormone. This spikes to initiate puberty. I probably know that. It's going to stimulate the anterior pituitary to release which hormone? Two hormones, gonadotropins or gonadotropes, whatever you want to call them. So luteinizing hormone and follicle stimulating hormone. We abbreviate them LH and FSH. So we're not going to focus on the reproductive pathways much. We're going to try to focus more on just the hormone part, because reproductive system is next quarter. So what does LH do? There's two kinds of cells. So here's the follicle. So around the follicle, there's two cells called theca cells and granulosa cells. and these produce your hormones. So LH stimulates the theca cells. This isn't the whole hormonal pathway. You don't need to know that. The two parent hormones are dihydroepiandrosterone, DHEA, and another hormone called pregnenolone. Okay, pregnenolone. So these hormones are the parent hormones. So progesterone's formed from these, and progesterone's released. So we see a spike in progesterone during the second half of the uterine phase, so in the luteal phase of the ovary, or we call it the secretory phase of the uterine cycle. Don't need to know that yet. And we get androstenedione. Any hormone with andro is an androgenic hormone. Come down here. So we can't say that androgenic hormones like testosterone are male hormones and estrogenic are female hormones. I wrote masculinizing and feminizing. It's a little bit different. So all men and women have androgenic and estrogenic hormones in differing amounts. In general, males have testosterone levels or androgenic hormone levels 10 to 20 times that of females, and they have a special hormone called DHT, or dihydrotestosterone, which is like the supercharged androgenizing hormone that females don't have. Okay, so all this means is they create androgenic and estrogenic effects, and they have their own effects. So masculinizing hormones, so body hair growth, deepening of the voice, stuff like that. Other things, increasing muscle mass, bone density. Estrogenic hormones, well, they create some feminizing effects, so fat redistribution, so breast development as well. And then all the reproductive issues or parts of estrogen. And estrogen is fantastic. Men and women both need estrogen. Estrogen's osteoprotective. It staves off osteoporosis. Cardioprotective. It gives you a better lipid profile. So women premenopause have much lower rates of myocardial infarction and atherosclerotic cardiovascular disease, ASCVD. They also aren't getting a bunch of horrible osteoporosis, right? But postmenopause, when estrogen levels fall, this starts to happen. So that brings up the whole question of hormone replacement therapy, which is becoming more and more accepted. Anyway, so LH is going to stimulate these hormones, especially androstenedione. Androstenedione is going to move from the theca cells to the granulosa cells, and the granulosa cells, androstenedione, will convert into two hormones. So really it gets converted to a hormone called estrone, and then estrone gets converted to estrogen, or we call estradiol. There's actually three types of estrogen come up here, E1, E2, and E3. So E1 is estrone, E2 is estradiol. That's the one that has the most estrogenic effects that we really talk about. When you just get an estrogen level, really we're talking about getting an E2 level, an estradiol level, and that's what women take for hormone replacement therapy. And E3 is estriol. So actually estrone then gets converted to estrogen. Don't need to know that. Then androstenedione also gets converted to testosterone. Okay. Testosterone can also get converted to estrogen through an enzyme called the aromatase enzyme. So the aromatase enzyme converts testosterone to estrogen. This happens in males as well. Okay. So male effects with hormones, there's two types of cells. I don't know if I have this in the next slide or not, so I'll talk about it. So again, FSH is going to help stimulate these reactions in the granulosa cells. So that's how those two hormones affect hormone production. Luteinizing hormone stimulates ovulation, and then FSH also stimulates development of the follicle. But again, that'll be next quarter. So males in the testicles, in the seminiferous tubules, this is a little tubule. Okay, little sperm cells developing in here. We have two layers of cells. So the cells surrounding the tubule are called Sertoli cells. FSH here stimulates the Sertoli cells to make sperm. LH stimulates the Leydig cells to make testosterone. That's it. Testosterone can then get converted to estrogen via the aromatase enzyme, and it can get converted to that very super androgenic hormone, dihydrotestosterone or DHT, through an enzyme called 5-alpha reductase. So you might see some drugs called aromatase inhibitors. You've heard of those. So anastrozole, the other one's called, I can't remember the name. The brand name is called Aromacin, and then letrozole. So they're aromatase inhibitors. They block estrogen levels. So we might use those, especially in estrogen-sensitive breast cancers, because we block estrogen, which isn't the healthiest thing. But if estrogen is stimulating growth of the tumor, it will decrease its growth, which is good for now. Let's survive the breast cancer and worry about the estrogen layer, because it'll come back. Oh, exemestane, yeah. So, so anastrozole is Arimidex. exemestane is aromasin, and letrozole. I can't remember the brand name of that, but you don't need to know it, so I don't know why I'm even talking. Okay, so this is showing this again. So males, here we go. I got it. So LH is stimulating cells to make testosterone. FSH can help facilitate that to some degree. And FSH is stimulating Sertoli cells to make sperm cells. So again, testosterone can get converted to estrogen right here through the aromatase enzyme, and to DHT, dihydrotestosterone, through 5-alpha reductase. Sometimes we block 5-alpha reductase in patients with benign prostatic hyperplasia because DHT also binds to receptors in the prostate, stimulating prostate growth, stimulates androgenic alopecia, so males' hair falling out, and also binds to receptors in the penis, stimulating erection, and lots of receptors in the brain. So we also have to remember the hypothalamus is part of the limbic system. We talked about the fourth F. The fourth F is reproduction. So, of course, estrogen, DHT, testosterone, they're going to cross the blood-brain barrier, bind to receptors in the brain, and you better bet they are going to affect our reproductive behavior. For sure. Okay, those are the three main pathways. So we had hypothalamic pituitary thyroid pathway, hypothalamic pituitary adrenal pathway, and then or axis, we should say, and then hypothalamic pituitary gonadal axis. So the gonads were ovaries in females, testicles in men. So growth hormone pathway. So growth hormone releasing hormone stimulates the anteropituitary to make growth hormone. Growth hormone has its own effects. Okay, as released in pulses, about 7 to 8 to 10 pulses a day, the largest ones before bed, affected by nutrient intake. So when we eat, growth hormone levels are actually suppressed. When we're in a fasted state, growth hormone levels are actually higher. So actually sometimes we test this by giving a glucose load, and growth hormone should be suppressed. If it's not and stays high, well, that's a sign of possible pituitary tumor pumping out growth hormone. So growth hormone has its own effects, but a lot of it's also getting converted to IGF-1, insulin-like growth factor 1 in the liver. And IGF-1 is called insulin-like because it stimulates nutrient uptake. Okay, nutrient uptake also stimulates fat mobilization and stimulates growth. Well, it's great when you're growing. We have higher levels of IGF-1, and normal levels of IGF-1 or ranges are actually higher for different age groups. So they're higher when you're 10 and you're 15. Then as we get older, IGF-1 levels go down, and we have different ranges of what's quote-unquote normal, whatever that is. But why do we need IGF-1 as an adult? Well, maintaining tissue health, right? It's going to bind to receptors off the body, stimulate bone density, healing of wounds, healing of tendon injuries. So that's why some athletes take growth hormone, because more growth hormone, more IGF-1, it's going to speed up healing of injuries. But it's not an FDA-approved reason. Okay, so that's why checking growth hormone level is hard, because it was released in pulses unless we're doing a glucose suppression test of GH. So usually we check IGF-1 levels because they're more stable. So IGF-1 levels are going to show us how much growth hormone we're making. I would know that. So diseases, dwarfism, so pituitary deficiency, so you have low growth hormone, low IGF-1. So what's happening if a child is developing and they're going down, 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 down on the growth chart, they're not growing. So we check the growth hormone levels potentially, or the IGF-1 levels, and they're low. So these kids need growth hormone. This is the only FDA-approved reason for growth hormone, is for dwarfism or pituitary deficiency of growth hormone. So some people also use growth hormone. Some clinics are prescribing it for anti-aging purposes because it improves collagen synthesis, skin health, bone health, potentially muscle mass, all that stuff that people want. But one downside is if you do have a growing tumor or a cancer, this potentially could increase the speed of growth of a tumor. So tumors definitely have growth hormone receptors. So high levels of growth hormone. So two diseases, gigantism and acromegaly. So gigantism and acromegaly are both caused by a pituitary tumor. So there's high levels of growth hormone, high levels of IGF-1. So here, obviously, how do you diagnose this? Well, get an MRI. There's a pituitary tumor. First, you'd probably check GH or an IGF-1 levels, and then that nutrient or glucose suppression test of growth hormone. You try to suppress it with a big glucose load, and GH stays really high. So gigantism, the only difference here with gigantism, patients have large stature, so they get very tall, like 7 feet tall, and acromegaly, they have normal stature. So what's up with that? Well, Gigantism, the patients are skeletally mature, so their growth plates are not closed, so they get very, 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 very tall. In acromegaly, so a 40-year-old dude develops a pituitary tumor, they're not going to get any taller. Their growth plates are closed. So when we get spike in GnRH, we go through puberty, sex hormones are going to promote closure of growth plates. Does anything grow in acromegaly? Yeah, weird stuff. The hands and the feet. So people's rings don't fit all of a sudden, their shoe sizes go up, their tongue grows, macroglossia, this can actually cause sleep apnea. And things in the skull, the mandible, the frontal bone, just overgrowth of the joints, people have lots of joint problems, and ultimately this can lead to growth of organs, especially the heart. Can your heart grow big? Not really. This causes cardiomegaly, which can lead to heart failure and death. Okay, so not good stuff. So I would know that for testing purposes, probably important. So how do you treat these two? Well, you cut out the pituitary tumor. There you go. That's simple. And if you have someone with gigantism and you don't remove the pituitary tumor, they will go on to having acromegaly. Okay, so prolactin. So what does prolactin do? Well, prolactin is the last hormone made by the anterior pituitary. So we've had TSH, we've had ACTH, we've had LH, FSH, GH, and now we have prolactin. So prolactin really doesn't have a releasing hormone. Some people say different things about this, like TRH might increase prolactin, but really it's antagonistic with dopamine. So dopamine in this area, not globally in the brain, if we have lower levels of dopamine, we have higher prolactin. Okay, if we have higher dopamine, we have lower prolactin. That's antagonistic or an inverse relationship. Inverse relationship. So the function of prolactin in females is milk production when it's time, after having a baby. In males, prolactin, we're not 100% sure actually, but we think spikes in prolactin after sex, because during sex and then orgasms, dopamine is really high. Then it falls, prolactin spikes. So we're thinking, some people disagree with this, but this is what we thought for a long time, and it's going to cause a refractory period. So inability to have another orgasm for a period of time, whether it's minutes, hours, or days. So really what's important for testing purposes is prolactinoma, so high prolactin. So this could be due to a tumor called a prolactinoma. It could also be due to certain medications. So sometimes we give drugs that are dopamine antagonists, blocking dopamine. Some of the antipsychotic drugs can do that. So if we're antagonizing or blocking dopamine, keeping it low, prolactin can be high. So we can have some of these same symptoms in patients on certain medications. And that's probably more common than a prolactinoma. But we use this because it's an easier way to talk about it. So prolactinoma in females, this is going to cause galactorrhea, so lactation, and they didn't have a kid. Amenorrhea, so loss of a menstrual cycle, and because it's inhibiting the release of GnRH, you're going to have lower levels of LH, FSH, completely dysregulate the menstrual cycle, and this can lead to infertility. In males, galactorrhea as well, because males do have mammary glands. They can be lactating, erectile dysfunction, so permanent refractory period, and then because we're inhibiting GnRH and LH and FSH and all that stuff, well, lower sperm count. So that's prolactin. So the parathyroid glands. So parathyroid glands are near the thyroid. There's 4 little areas of cells called the parathyroid glands, and what they do, they regulate blood calcium. They're not controlled by the hypothalamus. So as blood calcium levels are decreasing, it's going to stimulate parathyroid cells to release PTH. PTH is the abbreviation for parathyroid hormone. Parathyroid hormone is going to stimulate the bone to release calcium from the bone, so it's going to break down hydroxyapatite with osteoclasts, so that increase blood calcium. Go to the gut, increase absorption of calcium from our diet, so food or supplements. That's why people, well, never mind about that. And then the kidneys, we're going to increase calcium retention. So these 3 things. They'll increase calcium, and then it'll regulate our blood calcium levels. Pretty simple. Okay, but low calcium is going to stimulate the release of parathyroid hormone. So just like hypothyroidism, we're going to have hypoparathyroidism. Just like we're going to have hyperthyroidism, we're going to have hyperparathyroidism. So hypoparathyroidism. So we'll have low PTH. Well, if we have low PTH, well, we're going to have low blood calcium. So low, low, low. People get hypocalcemia. We know calcium is important for muscle contraction and nerve conduction, so people get all kinds of symptoms like paresthesias or numbing or tingling of their nerves, and they can get muscle spasms and tetany and all that stuff that you'll learn later. In hyperparathyroidism, you have high PTH. If you have high PTH, you're pulling calcium from the bone, from the gut, from the kidneys, so you have hypercalcemia. So this can lead to something called the bones, stones, groans, and sometimes we say moans, but the first three are probably the most important. So bones, bone pain because you're pulling calcium out of bone. Kidney stones because you're retaining all this calcium and reabsorbing all this calcium in the kidney, and you can get calcium stones. And then groans, so GI pain. The moans are sometimes psychiatric disturbances. Escape calcitonin. So calcitonin is released when there's high blood calcium. I must have erased it and then put this on here. So calcitonin actually stimulates bone formation because it's got to get this calcium out of the circulation, and it's going to cause you to pee out more calcium. So it's going to affect the bone. It's going to affect the kidneys. It's released from C cells or extrafollicular cells from the actual thyroid gland. So the thyroid gland makes calcitonin, released in response to increasing calcium. It's going to shove the calcium into bone. It's good for bone. There's actually a drug, intranasal calcitonin for osteoporosis, and it's going to make us pee out more calcium. It's not going to affect the gut, calcitonin. Now, vitamin D plays in this whole calcium regulation thing, and vitamin D does act as a hormone. It's that important. So vitamin D cares about bone. PTH and calcitonin don't care about bone. All they care about is blood calcium. Vitamin D is going to stimulate bone formation, so stimulate osteoblasts, form more hydroxyapatite. It's going to increase absorption of calcium in the diet. That's why you should take vitamin D with calcium supplements if you need to take those. And it's going to increase calcium retention in the kidneys. But if you take super high levels of vitamin D, one of the side effects is kidney stones and damage to your kidneys. Okay, last topic here, the pancreas. So the pancreas is our last endocrine organ. It has two portions. It has an exocrine portion that releases digestive enzymes and bicarb. These are acinar cells, An endocrine portion of the pancreas are these cells, these areas of cells called the islets of Langerhans, these balls of cells. These balls of cells are made up of 5 different kinds of cells. They release all kinds of different hormones. There's 2 that are the most abundant and the most important, the ones that'll be tested over. The other 3 will not be tested over. So we'll get to the exocrine, pancreas, and digestion later. So this is a really important slide. So 30% of the islets are made of alpha cells. I have this nice color coded here of the ball of cells here. There's blood vessels entering because we know these cells release hormones that get dumped into the blood and circulate through the body. That's how hormones work, and they bind to receptors in their target tissues, which we talked about in class. So 30% of the cells are alpha cells, 60% are beta cells. So it's 90% of islet cell mass, and the last 10% are these cells that make these other hormones. So alpha cells make glucagon. They get released in response to lowering blood glucose, like hypoglycemia. Glucagon is also a catabolic hormone, like cortisol. It's going to increase blood glucose. That's its function. What does it do? It goes to the liver. It causes glycogenolysis and gluconeogenesis, just like cortisol. So glucagon gets released in response to low blood glucose, and its function is to increase blood glucose. Don't get tripped up with wording on exams. So beta cells release insulin. Insulin functions to decrease blood glucose, so it gets released in response to increasing blood glucose, and it functions to decrease blood glucose. How does it do this? Well, binds receptors in skeletal muscle in the liver to store glycogen, binds the adipose tissue to store glucose as adipose tissue, as fat through lipogenesis, and all kinds of other tissues, right? Because tissues need to take up glucose for energy, so it's going to bind receptors all over the body and stimulate glucose uptake. So we see this here. So what causes insulin release? So hyperglycemia. So glucose readily enters beta cells, and that's going to stimulate insulin release. There's a few mechanical steps there you don't need to know. Also hormones like GLP-1, glucose like peptide 1. So all those GLP-1 agonist drugs like Ozempic and Mounjaro, they were originally made for diabetics because they stimulated beta cells to release insulin when beta cells were dysfunctional, right? Type 2 diabetics we use this in. There's also other hormones. One's called GIP or GDIP, glucose-dependent insulinotropic peptide, which is also a drug target which will bind to the beta cell and stimulate insulin release. Either way, we make something called pre-proinsulin. Pre-proinsulin breaks down to this proinsulin. Then proinsulin gets released, but it has to break off part of the protein. So insulin's a protein hormone, and you release this small peptide called C-peptide. So why it's underlined, so C-peptide is a good marker for how much insulin you're making, because most insulin gets taken up by the liver, And then insulin levels vary throughout the day based on feeding, right? We can get a fasting insulin level in the morning and see what our insulin level is. So high levels of insulin are usually a bad sign. Because the more insulin sensitive you are, the less insulin you need in response to carbohydrates and even to cover your basal insulin, right? Because our pancreas is always making insulin 24 hours a day, 7 days a week, 365 days a year, just in low amounts. We call our basal insulin, and then it has to spike or increase after a load of carbohydrates or food. That's why type 1 diabetics who make no insulin or very little insulin have to take a long-acting or basal insulin along with rapid-acting insulins to cover carbohydrates in meals. So C-peptide is a great marker for how much insulin you're making. So a type 1 diabetic would have undetectable or very low C-peptide. Anyway, to finish this off, these three last kinds of cells, there's gamma cells, a lot of times we call them PP cells or pancreatic polypeptide cells. They make pancreatic polypeptide. Pancreatic polypeptide slows gastric emptying. Delta cells make somatostatin. Somatostatin inhibits glucagon and insulin release. And epsilon cells make ghrelin. Ghrelin's mostly made in the stomach, and this is a satiety hormone. It circulates the blood to the hypothalamus. The hypothalamus regulates appetite. It stimulates satiety. So does GLP-1. So this last thing here, I'll just throw this on because I can't go backwards for some reason. So diabetic complications, we get to diabetes. Diabetic retinopathy, nephropathy, and neuropathy. This is triad of what diabetes does. So high levels of sugar damage your blood. So if your fasting blood glucose is between 60 and 99, really you've got about a teaspoon or so of blood glucose, or sugar in your blood. So very, very, very little if you think about it. But high levels of glucose, you go up to 5 teaspoons of glucose, it'll start damaging all this stuff in your body, especially small blood vessels. It forms these things called advanced glycosylation end products, which are tissues that are bound to glucose, and it damages it. Just think of glucose being sticky and sticking to lots of things. So diabetic retinopathy can lead to vision loss. Diabetic patients should be getting an eye exam at least once a year. This can actually lead to blindness. Diabetic nephropathy, so this damages the small blood vessels in the glomerulus and slowly decreases your GFR or the filtration ability of the kidneys, leading to chronic kidney disease. And this can go all the way to stage 5, which is end-stage renal disease requiring dialysis or a renal transplant. Diabetic neuropathy, well, you can't feel your feet. So initially people might get paresthesias or some numbness or some burning pain. And some people have noticed the progression of this, and they can't feel their feet, so they get diabetic foot ulcers. They can rub these specific wounds on their feet inherent to patients with neuropathy or their neuropathic ulcers. This can lead to amputation, so loss of a toe or a partial foot, and then this can lead to limb loss. When I say limb loss, I mean below the knee or above the knee amputation. So hyperglycemia or diabetes is also an independent risk factor for atherosclerotic cardiovascular disease, peripheral arterial disease, cerebrovascular disease. So it's very bad for your blood vessels. So there's two types of diabetes, type 1 diabetes mellitus, type 2 diabetes mellitus. We talked about these subtypes. There's two subtypes of type 1, so SAD or severe autoimmune diabetes. So diabetes type 1 is an autoimmune disease always. So there's beta cell destruction. Okay, so autoantibodies attack the islets of Langerhans. There's actually multiple autoantibodies. The one we use for blood tests, usually that's easiest to isolate, is GAD, so glutamic acid decarboxylase 65 autoantibodies. Okay, so if these are found in the blood, we have autoimmune cause, we have type 1 diabetes. What causes type 1 diabetes? Is it genetic? There's some genetic predisposition. We've proved that. It could be post-viral or mental environmental exposure. So if you're genetically predisposed to type 1 diabetes, you have a certain viral or environmental exposure, and then you can develop these autoantibodies. Usually in children and adolescents, but we can't call it juvenile onset diabetes anymore because we found the subtype LADA or latent autoimmune diabetes adult. It's exactly the same as SAD, a little bit longer time for onset basically, but type 1 patients, adults can develop type 1 diabetes just like kids, much lower amount, but it can happen. So here, same thing, low C-peptide because we're getting minimal insulin release, and then positive GAD autoantibodies. Now, you have 4 subtypes of type 2 diabetes: SID, SIRD, MOD, and MARD. So SID is severe insulin deficient diabetes, and SIRD is severe insulin resistant diabetes. So in both types, there's insulin resistance, right? But in SID, the beta cells are releasing less insulin. So yeah, what's the whole beta cell function in type 2 diabetes? Well, initially there could be high levels of insulin, but over time they could burn out or make less insulin. So this subtype people have less insulin production, and there's debate talking about, well, people with SID are more likely to go on insulin because type 2 diabetic patients go on insulin. Well, that makes no sense because they make insulin probably too much and they have insulin resistance. But some patients, the beta cells burn out or the beta cells are dysfunctional, so they might be candidates for insulin. But that's more controversial to actually look at C-peptide levels to determine on therapy. So both have insulin resistance, but SID, the beta cells are dysfunctional, so drugs that would increase insulin release from the beta cells or giving insulin might be more beneficial. So there's decreased insulin levels, maybe a lower C-peptide. They're a high risk for retinopathy and neuropathy. So SIRD patients, they have severe insulin resistance, so potentially higher levels of insulin at first. They usually have a stronger family history, or both of these do actually. And SIRD patients have a high risk of nephropathy. So we've done that with studies. SID, high risk of retinopathy and neuropathy. SIRD, high risk of nephropathy. Okay, and both these have a strong genetic predisposition, and usually there's a younger age of onset. And these last two, MOD and MARD, so we got mild obesity-related diabetes and mild age-related diabetes. So mild obesity-related diabetes, this is usually due to lifestyle. These patients are generally morbidly obese, which is a BMI of 40 or greater. So obviously they need to change lifestyle factors. So the biggest thing is weight loss. So exercise improves insulin sensitivity. Decreasing caloric intake, especially carbohydrates, can increase or improve insulin sensitivity, and so can weight loss. Of course, exercise and decreasing caloric intake will lead to weight loss. And these patients oftentimes have bariatric surgery, and it significantly improves their insulin sensitivity. MARD, mild age-related diabetes. I didn't write anything there because just people develop insulin resistance as they get old. So this is like the 70 or 80-year-old that has diabetes. Unfortunately, SID and SIRD patients have a lot of complications, and unless they really do well, they'll have a harder time reaching these older ages. And we talked about mortality rates with dialysis and mortality rates with limb loss, and they're very high, usually about 50% at 5 years in diabetic patients. Last thing, how do we diagnose this? Well, the main two tests are fasting blood glucose level and a hemoglobin A1C. You can also check a postprandial blood glucose level 2 hours after eating, and an oral glucose tolerance test, which you can use for anyone, but generally we save this for gestational diabetes, and they have their own numbers, so don't even correlate that. So we see fasting blood glucose 60 to 99 is normal, 100 to 125 is pre-diabetes, and 126 or greater is full-blown diabetes mellitus. Usually we don't see pre-diabetes in type 1 because it's a faster onset, but if you do catch them at the right time, we might see this. Type 2 diabetics, it's a slow progression of insulin resistance, so we're more likely to see this in type 2 diabetic patients. So hemoglobin A1C, so this test we discussed in class, so it's the percentage of red blood cells that are connected to glucose or glycosylated, so glycosylated hemoglobin. It's a great test because red blood cells live about 90 to 120 days before the spleen takes them up. So it's showing how our blood glucose looked for the last 90 to 120 days. The fasting blood glucose is telling what our glucose is right now, this second in time. So this is a great test to see how people are doing, because if someone's glucose is terrible, then they take a bunch of insulin, get a fasting blood glucose level, and it looks good. Well, that's kind of tricking the system. We see levels there, so less than 5.7%, 5.7 to 6.4%, and 6.5% or greater. So postprandial glucose, so after 2 hours it should be less than 140. After 2 hours, 140 to 199, and 200 or greater after 2 hours, that's diagnosing diabetes. So really, even a random glucose, if you just ate a meal, really glucose should never be 200 or higher. Oral glucose tolerance test, you get a load of glucose, either 75 grams or 100 grams, and we can check glucose 2 hours later. That's what this is showing, same numbers as a postprandial glucose. But again, you can check them 30, 60, 90 minutes afterward, and for gestational diabetes, it's different numbers. So gestational diabetes, this is diabetes developing in the second, third trimester of pregnancy, and we can't check an A1C because this is developing during pregnancy. And women that have gestational diabetes are at risk for developing type 2 diabetes, and their kids have a high risk of diabetes as well. Okay, that's the end.